Good morning, everybody. First of all, I want to thank everyone. First of all, I think this is a wonderful thing for the profession to be part of the summit. And I really want to thank Dr. Treppel and Dr. Wayne Axman for asking me to be here. And also PK, who is a good friend and a wonderful aid to our profession. So I'm going to be talking about hyperbaric oxygen therapy and transcutaneous oxygen therapy. This is a really brief overview and introduction. We're going to review the basic science of HBOT and transcutaneous oxygen therapy, present some basic clinical information, and provide a window into the future of different oxygen therapies. I have no disclosures to announce. Like Dr. Treppel said, I am an NYCPM graduate, very proud. I did a year at Wyckoff and a 3-year surgical residency afterwards at Mount Sinai through Dr. Wayne Axman, and it was really educational and probably one of the best times in my life during my training. I'm still technically on staff at Mount Sinai. I'm teaching the residents at Lenox Hill. I'm board certified in foot surgery. I'm a fellow, diplomat, and I'm also on the board of the American Society of Podiatric Surgery. All right, so what's hyperbaric oxygen therapy? It's a non-invasive procedure in which the patient is placed in a chamber containing 100% oxygen at pressures greater than 1 atmosphere absolute. The atmospheric pressure at sea level is probably about 14.7 pounds per square inch. When we're treating patients with hyperbaric oxygen therapy, we are putting them at pressures of 1.5 to 3 atmosphere absolutes are typically utilized. Most hyperbaric treatments last about 2 hours. Here's a little diagram to show you about the atmospheric pressure absolute. At sea level, it's about 1. Once we go down to about 33 feet, we're at 2. And our treatable conditions are at like 66 feet. So those are the 3 atmospheric absolutes. This is not hyperbaric therapy, all right? I'm sure that a lot of people have seen this, and there's a lot of times there's confusion between what is hyperbaric oxygen therapy and transcutaneous oxygen therapy, and that's one of the things that I'm here to do, is to clarify that for you guys. This is a hyperbaric chamber. These chambers are what we see in our outpatient centers and in our hospitals. There are some hospitals, some of our older hospitals also have these really large chambers, which you'll see one picture of that coming up shortly. So Henry's gas law, all right? At a constant temperature, the amount of gas that will dissolve in a liquid or into the body of tissue is proportional to the partial pressure of the gas in contact with the liquid. All right, that is how the hyperbaric oxygen therapy works, is that at the constant pressure, we will be diffusing the oxygen into the tissue. Here's our wound healing sequence, and we can see how instrumental oxygen is, as we all know, in the wound healing sequence, in order to stimulate the fibroblastic activity, which will lead to the collagen formation, capillary budding, as we see this cycle. HBOT. What does it do? All right, it decreases inflammation with certain cell markers and cytokines, tumor necrosis factor, interleukins. It's shown to be as effective as dexamethasone. It stimulates fibroblasts, collagen, and osteoblastic proliferation, and some controversy of mobilizing and stimulating the increase of stem cells within damaged tissue and bone marrow. And we'll see why HBOT is vital and crucial with stem cells and damaged tissue and bone marrow, because we can use this type of therapy in the presence of refractory osteomyelitis. A lot of people always say, how many treatments does hyperbaric oxygen therapy require? Well, the treatments are individually based per patient. Most patients will come into a hyperbaric center, or once they're refer to the hyperbarics in the hospital, they'll meet with a hyperbaric specialist that will determine how many treatments they need. Emergency cases with patients that have carbon monoxide poisoning, sometimes it's only one single treatment, all right? People that get the bends and stuff like that, those can be treated once or twice. Wound healing cases, which is our topic and our specialty, can take 20 to 30 treatments to achieve a maximum benefit. And our treatments are administered once or twice a day for 5 days a week. And the compliance issue, I think, is something that we all have to deal with. I'm just going to show you some examples here of hyperbarics. Now, of course, we all know that hyperbarics is an adjunct. We need good soft tissue debridement. We need circulation to the best of our ability. We need to maximize these patients in order to get these wounds to heal. Here's another example of another patient with a large gaping wound. So these are all debrided. They've all been treated with hyperbaric oxygen therapy, and they've gone on. This is a bad venous ulcer. Not in our specialty, but also burns. Hyperbaric oxygen therapy is vital for burn patients. So some of the other commonly uses for hyperbaric oxygen therapy: radiation tissue damage, crush injury and compartment syndrome, any other acute traumatic ischemia, air or gas embolism, gas gangrene, decompression sickness, refractory osteomyelitis, severe anemia, necrotizing soft tissue infections, our diabetic ulcers and select non-healing wounds, thermal burns. There are some retinal arterial occlusions, carbon monoxide poisoning and smoke inhalation, skin grafts and flaps, and sudden sensorineural hearing loss. Now, one of the other things is that when patients undergo hyperbaric oxygen therapy, you have to be careful because some of the complications of hyperbaric oxygen therapy can be temporary hearing loss. Hyperbaric oxygen therapy is good medicine. It's cost-effective for an individual patient. It's cost-effective for society and very cost-effective for most hospital systems. I think that the most advanced hospital systems always have hyperbaric therapy available to their patient population. We're going to move over to transcutaneous oxygen therapy. All right? You breathe continuously, perhaps your wounds should too. So the evolution of oxygen therapy. We're going to start with hyperbaric oxygen therapy in the 20s and 50s, right? So it's good. This is going to show you the progression of the phone also, all right? So you'll see how we started with these large chambers, a big mobile, immobile type of like encasement. And you can see over here where there's a patient that's placed over their head, and then below that is that big hyperbaric chamber, which is used for divers and astronauts, and to show you the different things. And as it evolved, here we come with our phones. Here are our chambers our individual chambers in the 80s. And then we have some portable units, such as that familiar picture on the bottom, which I was showing is another way of continuous diffusing oxygen. And now we're in the cell phone age where everything's wearable, right? So here's a comparison of some of the oxygen therapies, all right? We've got HBOT, we have the normal, and an ischemic wound, right? And here's one of the things that the continuous diffusing oxygen therapy says it has an advantage over other types of oxygen therapies. It's continuous, all right? So you continue to treat these wounds throughout the time. That intermittent process is not necessary. It's not they're going into a chamber and then they're coming out. These treatments are delivered 20 times longer than intermittent therapies, and transcutaneous oxygen doesn't take time off, or doesn't take the weekends off. How oxygen works? We know how oxygen works. It increases the mechanisms that are proportional to all our oxygen levels. As our oxygen increases, cell metabolism and energy production increase, wound closure increases, pain relief will increase, perfusion angiogenesis will increase, antibacterial activities will increase, collagen synthesis and tensile strength will increase as well. This is similar to the gas law, Henry's law before. It's showing that how the system of the oxygen is diffused into a larger concentration, going from the external environment into our body. The effective oxygen concentration is multiple enzymatic pathways, right? So as we increase oxygenation, it will increase the healing mechanisms on ischemic wounds, and oxygenated wounds will be accelerated, all their processes, all the metabolic processes. Topically applied oxygen is direct, it's local, it's not relying on underlying local capillaries. It diffuses rapidly into tissues, and it will continuously be brought to these tissues through the device. So here are some indications for use. Skin ulcerations resulting from diabetes, venous stasis, post-surgical infections, and gangrenous lesions. There are pressure ulcers, infected residual limbs, skin grafts, burns, and frostbite. Here are some of the contraindications. The wounds with inadequate perfusion to support healing, right? We can't, if there's not adequate perfusion, like the whole summit is about getting adequate perfusion. So that's what we need in order for these wounds to heal. Ulcers due to acute thrombophlebitis, Raynaud's disease, necrotic wounds with eschar or slough, which is another thing. Good wound debridement is essential to us healing these wounds. Wounds with fistula or deep sinus tracts with unknown depth, all right? So that's part of our debridement. So I got a whole bunch of studies over here showing us how continuous diffusion of oxygen, it doesn't depend on the capillary structures. This one's from biomolecules. This is a 2021 June study. It shows that the capillaries were not essential in the delivery of the oxygen. This is just one of the EO2 systems, Oxygeni system. It's got a power pack that's rechargeable, and it's a very simple way to treat some of the topical wounds. So it's wearable. There's a carrying case. It's weighs about 6 ounces, like a cell phone. It's very discreet. It's you could put it on, put it right on a cam walker or a surgical shoe. Goes right around, or you could tie it to your belt or your waist. So the Journal of Wound Care, continuous diffusion of oxygen enhances healing. There was a fully blinded trial, oxygen versus placebo, and moist wound therapy in diabetic foot ulcers. This study was a CMS study, and it was designed to eliminate any sort of bias. And what they had was they had patients that had the placebo and patients that had the active continuous diffusion of oxygen. And it turned out to be the gold standard for studies going forward with continuous, for CMS with continuous diffusing oxygen. And we saw that the wounds were closed twice as fast with continuous diffusion of oxygen relative to our typical moist wound therapy. Growth factors and cytokines, from a few slides back, you saw that the continuous diffusion of oxygen treatment will increase the cytokines, perfusion, bacterial load, and healing in patients with diabetic foot ulcers. And what this study showed was one of the things that you'll see is when you use continuous diffusing oxygen, transcutaneous oxygen therapy, you will see a huge spike in these cytokines. The first week, you're going to see a lot of exudate, and you're going to think, oh no, the wound is infected, but it's not. It's actually stimulating all these cytokines and increasing perfusion, and it's starting to make the wound heal. And this is just a depiction of that on this graph over here. We got the tumor necrosis factor, PDGF, platelet-derived growth factors, interleukins. This reflects the clinical experience with continuous diffusion oxygen. Marked increase of exodus in the first week, then reducing over time. The expected physiological response from growth factors and cytokines are involved. Wound Central, this is a pain study that was done with transcutaneous oxygen therapy. It's amazing how much pain relief we were able to get with some of the wounds that we see, and it's fairly rapid. You'll see that there's another really interesting graph. 39% were pain-free. Several were 100% at day one. It decreased the use of narcotic use in a lot of these patients as well. Closure and pain. This is very similar. I just said 80% experienced significant or full closure. In the wounds, the pain relief was dramatic. 75% were pain-free by the first follow-up. Here's a venous ulcer case that we saw. The wound duration was 5 months. And you'll see that continuous diffusion of oxygen therapy can be anywhere between 50 to 100 days before you'll see significant wound closure. It shows us that we did CDO 10 milliliters per hour. We did it. So this is the pain reduction. So you're going to see that as soon as they started the continuous diffusion of oxygen, the patient's pain scale went down significantly from an 8 to a 2. Then they put it on hold. The pain went right back, and then they restarted the continuous diffusion of oxygen. And eventually at day 80, they had 0 pain, and as you can see, they were fully closed. This was out of the Baylor College of Medicine. This was a poster in May of 2020 to improve foot amputation. This was a pilot study that showed a control group of 18 people undergoing foot open surgery. 11 of them got continuous diffusion of oxygen, and the other were just closed, right? And you're going to see that there was a noticeable trend in the incidence of tissue necrosis was 0 with the CDO versus 43%. Successful healing was 75% with the CDO versus 29%. And the wound length reduction was 70% greater with CDO. So here's one last study. I'm going to lose my foot, right? 87-year-old diabetic COPD, venous insufficiency, 3rd and 4th toe amputation, and subsequent osteomyelitis. Day 0, we have a nice fibrotic wound over here. Day 30, and here we go on day 75. Closed, small dry eschar, a little bit of fibrosis in there. Here's a couple other examples. And you can see day 0 to day 60. There's a Mohs procedure for melanoma on a wide excision on the head. Day 44, complete closure. A coccyx ulcer, 73 days, wound was healed. This is a nice foot, and this is about 93 days, 99% closed. The average wound before CDO therapy, there's another in the registry, there's 299 days. And in 65 days, as soon as continuous diffusion oxygen therapy, we had a 76% success rate with wound closure. So here are some of the benefits of continuous diffusion of oxygen therapy. It's cost effective. There's pain reduction. It's wearable 24/7. You get full wound healing, and it's naturally antibacterial. And that is my